Good evening, everyone.
Hi, Ann.
Thank you for sharing your evening with us tonight. And welcome to the Goodrich. This is our new building, and we're proud to be able to have this event here in our new building. So I'm very excited. This is one of the series, the M&M series. We've been having it for numerous months now. I think maybe this is our 6th event. I'm very excited about tonight's topic, Alzheimer's Now What, and very excited for this panel before me. They have a wealth of information that they're eager to share with all of you. We have Jennifer Labrie from the Alzheimer's Association, Heather Dober, who's in her own clinical practice, and Tully Meyer, who's with us here at McLean. We're going to start with Jennifer, and then we'll make our way through the panel. So Jennifer is a dementia care consultant for the Connecticut chapter of the Alzheimer's Association. She connects people who are living with dementia, as well as their care partners and families, with the resources and the support systems to achieve the optimum quality of life. Jennifer has been with the Alzheimer's Association as a volunteer and staff member for over 20 years. Previously, she was a program director of a memory care neighborhood in an assisted living community. Jennifer?
Okay, so can you hear me okay? I don't know if it's closer and lower. Can you hear me? Good? No? Hello? Yeah. Better? Okay. Closer to here? Okay. Okay, so I'm Jennifer. Can you hear me now still? Yeah. Okay, good. If you start to not hear me because I drift away this way and you can't hear anything, then tell me to move back. Would you rather have this? Is that better?
Oh, yeah.
Okay, I have to be careful not to scream in your ears. Okay, so that was me. I hope I live up to everything that Ann said. I can't believe when I hear 20 to 25 years I've been doing this, but I have, and I'm no expert. I learn every day along with everyone else, and I'm happy to share anything I know with you. Hopefully it helps you through your journey. You've heard about me, and you're going to hear about Heather and Holly. Oh my goodness, I'm so sorry. No, I got it. But what I would like to know by show of hands from you, who in this room is here because you have concerns about yourself, or caring for a loved one that you have concerns about, or has been diagnosed, or just know somebody who is facing dementia, Alzheimer's, or memory concerns, just by show of hands. I want you to look around at your hands. I'm going to raise mine too. You're not alone. No matter what I say for the next 15 or 20 minutes before I pass it to Heather, know that you're not alone in this, and that's the overall message I want you to get tonight, okay? So, seeing all of those hands, one thing I'm going to share before I start jumping into what's Alzheimer's dementia, what's next, one thing I'm going to share is that annually the Alzheimer's Association puts out a facts and figures report in March. So last week, our facts and figures came out. And on that facts and figures, we always state around 6 million people are living in the United States with Alzheimer's. Well, it's known now 6.7 million Americans are living with Alzheimer's disease. 80,000 people right here in Connecticut are diagnosed and living with this disease. It takes twice as many caregivers to care and support for somebody with this disease and going through this journey. So by you raising your hands and knowing that so many people are affected, you're not alone in this journey. There are resources, help, and support. We know also that by 2050, this is going to double. So we really need to talk about this, right? And really need to know what's next and what's out there to support. I've done this for 25 years, but I don't want to forget anything to tell you, so I use my cheat sheet, okay? Another thing that this report came out with was talking about a special report, the patient's journey. In that special report, it talked about what's not being talked about. We know that 7 in 10 people have concerns about memory, or going into their doctor's office, and they want to know if this is a true concern or not, if this is a true issue. But only about half of those people, 4 out of 10, are bringing it up to their primary care physicians and talking about it for a few reasons, which I'm guessing you would know. Out of fear, right? If we bring it up, we talk about it with the doctor. What if we get that diagnosis? What then? People are more comfortable with family members, friends, discussing these things rather than with their doctor. And people also chalk it up to, and I do this myself, oh, it's just normal memory changes. Oh, I'm just getting older. I'm just getting a little more forgetful. And really and truly, we need to bring these things up in our doctor's offices. And so on the flip side of it, primary care physicians say that they're waiting for people to bring it up, to have this conversation, for people who have concerns for themselves, family members who are accompanying them in the doctor's office, but people aren't bringing it up. And primary care physicians are also concerned, if people bring it up, I'm having this conversation with them, there's lack in the workforce, a shortage in the workforce of geriatricians and specialists to then refer people to. So if we talk about those numbers, we talk about those concerns, people not bringing it up, there being a shortage in people to help in terms of geriatricians and specialists, we're looking at a public health crisis, right? So my call to action before I jump into education with you tonight, here and now, if you have concerns for yourself, if you have concerns for a loved one, bring it up, talk about it, go to your physician. Even though there's a shortage in workforce, we know, in home health aides and assistants in residential care and geriatricians, we can help you find those resources through the Alzheimer's Association, Heather, Tully, any of us. So there is help. Okay. So enough about that, my call to action to have you all talk about this. This is a critical time. For the past 20 years, more, we've only had medications that treat symptoms. We're now in an era where just in the past year and a half, they have approved, FDA approved 2 drugs that actually alter the disease process that's happening in someone's brain. I don't know if you've heard in the news, Aduhelm and Leqembi are the 2 drugs. We're now trying to work with CMS, Medicare, Medicaid to get those drugs covered and get access for people. That's not yet in place, but we have those drugs that have been approved and more in the pipeline. So to gain access to that, it's important to talk with your doctors, get that diagnosis, and know what you're facing. Okay, and Anne, this is what I think you wanted me to cover, right? Okay, so what is Alzheimer's? What's next? When I'm talking for the next 5 or 6 minutes, I want you to picture the umbrella, okay? And watch my time too, because if I talk too much, tell me to stop. You do it, you poke me. So picture the umbrella, right? I didn't print a lot of handouts or anything, but people have so many questions when they call our helpline or I'm having a conversation with someone. What's dementia? What's Alzheimer's disease? How are they related? How are they different? So I'm going to kind of level the playing field here, or set the tone. Dementia is an umbrella term, so picture the umbrella, right? It's an overall term that's talking about symptoms. Symptoms that can include changes in memory, in particular short-term memory. When we say that, we mean recently learned information, new information, is quickly forgotten, it's not retained. Changes in judgment, so poor judgment, decision-making skills change, thinking skills. It can change behaviors, the way you communicate, the way you process information, the way we interact with each other, personalities, relationships. Am I right? If I do say anything wrong, you can correct me too. Good thing to work with good friends. So that's dementia, right? Symptoms. We're using that term to refer to symptoms. Dementia itself is not a disease. There are causes of dementia, actual diseases that are causing dementia. So when I look at that umbrella again, the raindrops are on the other side, you see different names. Alzheimer's disease, #1 cause or type of dementia that is diagnosed, attributing for 60 to 80% of the cases of dementia that are diagnosed. So that's why we hear so much about Alzheimer's. There are other types of dementia out there, vascular dementia related to cardiovascular issues, stroke, Lewy body dementia, frontotemporal dementia. We hear about more rare, sometimes Huntington's disease. People can have mixed dementia where you have 1 or more of those diagnoses at a time. So there's dementia, general term. There are causes or types of dementia, the actual disease process that's happening in someone's brain to cause those changes that cause what we see on the outside and the actual symptoms. Now, people will ask, well, what's normal age-related change? How do I know it's not just normal age-related change? If it's not significant enough to change how you're functioning day to day, and what I mean by that is a normal task that maybe we all do is we get up, we remember we have a doctor's appointment at 1 o'clock today, we take our shower, get ready, get in the car, go ahead to the doctor's appointment. If something were to happen and there was such significant change in our processing that we skipped that doctor's appointment, or we got in the car, put the key in the ignition, and didn't know what the next step was. Significant changes to our abilities to function each day are what we want to definitely make sure we get checked out. If normal, age-relating, slower processing, a little bit harder to multitask when we're trying to do so many things at once, but your knowledge, your skill, your basic memory is still intact, right? One thing to mention, a couple of things medically can also cause dementia symptoms, but are not necessarily a dementia or a disease. They can be treated, and those dementia symptoms would be alleviated. We used to call them what? Pseudo-dementia? That's what we used to, I don't know if they refer to it like that anymore. But vitamin deficiency, thyroid condition left untreated, side effects from medications, excessive alcohol use, diabetes, depression. All of these things can cause someone to be confused, foggy, forgetful. But treat that depression, treat diabetes, regulate your thyroid, treat the vitamin deficiency, and that fogginess, confusion, and things will go away because it's not an actual disease causing it, it's a medical condition. How'd I do? Did that make sense? Okay. Is that okay? Okay. That's always everyone's biggest question. So, for my part, when we're talking about Alzheimer's disease, dementia, that diagnosis, what's next, Heather's going to talk about building that team. Again, don't go through this alone. You want to build a team of medical professionals, other professionals in your community, family, friends. Heather's going to talk more in depth about that. What I want to talk a little bit about is what we are in control of and what we can do, even though we're not in control of what the disease is doing to our brain and the progression. We can do things in terms of managing ourselves and taking care of ourselves. So a couple of things, knowing that you can live well with this disease. It's important to get that early diagnosis, and in the early stages, or even in MCI, mild cognitive impairment, which can be a precursor to Alzheimer's disease. So what can we do in those early stages? Number one, we can take care of our bodies. A heart-healthy diet is a brain-healthy diet. Mediterranean diet, people will follow or refer to your vegetables, your fruit, lean meats. Try to avoid the sugars, processed foods, processed meats, good grains we want to get into ourselves. So looking up and kind of investigating that Mediterranean diet to follow, along with exercise. Cardiovascular exercise, 20 to 30 minutes, something you enjoy. Incorporate it into what you love, your purpose, being with others. Is it playing tennis, taking a walk, going for a bike ride? You can couple all these things together, right? And doing things you enjoy, getting your heart pumping, blood flowing, oxygen to your brain. These are all things we can do. Maybe not to reverse the disease process, but certainly to delay, slow down, or help the symptoms that we're experiencing. I mentioned stay social while you're being active. We all know the past couple of years how different the world has been, COVID, right? I think anyone with or without dementia felt the effects of being isolated, not socializing with people, interaction, face-to-face, conversation in person. It took a toll on all of us, dementia or not, but especially for people with dementia and their caregivers, it was even worse. Depression, anxiety, social withdrawal. So get engaged, we're better. Use your mask if you have to, be together, come together, have meals, be active together. Finding purpose, challenging yourself, keeping your brain active, right? That old adage, use it or lose it. Keep your brain stimulated. You can still learn and do new things with this disease. Another thing I just want to mention, and I just kind of go through more of those steps of what to think about and what to do next, making sure that you have legal financial plans in place. Work with a financial advisor if you have one, an elder law attorney to help with some of these things, but most important, review documents if you have existing documents, wills, living wills. Do you have a power of attorney for financial durable power of attorney? Do you have a healthcare representative named or a healthcare proxy? Do you have your advance directives in place? Do people know your wishes? What do you want done? Who do you want to speak for you? Who do you trust to make decisions for you in a time where maybe you can't make those decisions for yourself or your loved one? Okay? A couple of other things, treatments and research. Get involved in a clinical trial, and I'll talk about that more in a minute, but early stages and MCI, precursors to this, healthy volunteers. If you have it in your family or you're caring for someone with disease, there are opportunities for clinical trials for healthy volunteers as well. Get involved in research, get involved in clinical trials. You're gonna have access to expert care, but also possibly that new treatment or that new drug that's coming and can actually halt this disease. Sharing your diagnosis with others, and I'm guessing you're gonna touch on this too with your team when you build that care team, but talking to people, letting people know what you're going through, squashing that stigma and finding support through talking with others, because as we all saw hands go up in this room, you're not alone in this. You're not alone in caring, you're not alone about concerns, or even if you're diagnosed. I'll mention too some of the wonderful groups that we have in a minute. One of the key things I feel like you can do for yourself with this diagnosis, and as one of those first next steps, when people walk out of the neurologist's office or the doctor's office, very often it's, we'll see you in 6 months or we'll see you in a year. That's a lot of time to sit and process that diagnosis and wonder, what can I be doing? So some of those things that I mentioned that you can be doing, I have information I can share, we have a helpline that I can share, but another thing you can do, absolutely educate yourself and educate others that you're sharing the news with on what's out there and what can help. Educate yourself on the disease and what your official diagnosis is, even if it's another type of dementia. Educate yourself about the disease. Educate yourself about the services and resources and supports that are out there. So I'm going to do my Alzheimer's Association tout right now, if that's okay, because we have so much to support and help you with and connect you with. So the Alzheimer's Association, since 1980, we've been around. I haven't been around quite since the beginning. I was a little young for that, but we've been the leading voluntary health organization for Alzheimer's care, support, and research. We're also the largest nonprofit funder of Alzheimer's research worldwide as well. When leaving that office, you're not often told where to go or what to do. I will tell you the number one thing I want you to know, and there are cards over there, is that we have a 24/7 helpline through the Alzheimer's Association. We can help with Alzheimer's and other dementias as well. 1-800-272-3900. I don't want you to write it down or remember it. There's a card over there I want you to take with that number on it. That number is for anyone, someone who has concerns for themselves, someone who's caring for someone, medical professionals, professionals in the community, somebody who's just curious about what is dementia or has other questions about this. Call the number 24/7, speak with a clinician, and get your questions answered. You can set up care consultations through that number for an hour to speak with a clinician over the phone or by Zoom right now, and put a plan together for yourself as well and what next steps might be. We also can answer simple questions like, I have this, I've been diagnosed, are there support groups for me? And so we have such an amazing, wonderful volunteer in Anne, who's right here in your community. Anne runs groups for us for people who are in the early stages, newly diagnosed, support groups for people to gather and talk about what they're going through, compare strategies, compare notes, how are people living with this and doing well? And also social engagement groups, so that we're not alone, we're doing some fun stuff, coming together, talking, laughing, learning together. We also have caregiver support groups. Anne runs a couple of those too, right? So Anne has a couple of support groups. Before COVID, we had over 100 in person in the state. Now we have groups, I don't know if we quite have that many, but we have virtually, we can reach more people. We have groups specifically for men who are caregivers, females who are caregivers. We have caregivers specific to spouses, adult children, or just general caregiver groups. So reach out if you need something and we can find a group that is right for you. Another thing that we have through the Alzheimer's Association, as I mentioned, education. We have in-person education programs, we have virtual programs you can join, and we have recorded online programs that you can watch at any time. We are a nonprofit helping people, and there is no charge ever to a caregiver or a family member or person diagnosed with this. We also have a wonderful website. I will tell you, it's wonderful in terms that it has a lot of information. It is so hard to find things on there. So alz.org, it's a wonderful wealth of information. Call the helpline for help to navigate it and find what you need, or call me. When I spoke about research and clinical trials. We have something, and one of my coworkers who's dating refers to it as what is it? What's the Match.com for dating? It's that for clinical trials. So you go in, I filled out the information myself at one point, very simple, takes 5 minutes. You put in your name, what types of trials you might be looking for, the area, your demographics, and it will match you up with trials and send you an email with the trials that are appropriate for you that you can look into and call a contact person and see if that is a good fit and if you'd like to participate. I talked about we fund trials worldwide. We fund trials right here in Connecticut as well, and research going on at Yale with Dr. Van Dyke in the research unit. We fund trials with UConn and Hartford Hospital at this time. So there are ones locally and there are ones nationally and regionally as well. And I also wanted to share with you that we are a public policy organization as well, and an advocacy organization. We encourage you to call, share your story. We are always bringing information to the Capitol for funding, for more dollars, more support for caregivers and people diagnosed that are going through this in this state. So please feel free to reach out. That 1-800 number, it can get you connected to anything. So I've talked probably about my 15, 20 minutes, yeah, not to go over. I'm talking about tangible resources, things you can connect with, things I can give you, or kind of like a checklist of things to do, right? When you walk out of the office with that diagnosis, you're caring for someone with that. There are a whole lot of emotions that happen and that go on, and that in itself is a lot to process on top of what you have to plan for. So I'm so fortunate because Heather is one of the greatest people and services that I refer to when people are going through this, and she's right here in our area. And Heather, you're going to talk about that care team and how to process and get through this. I hope that was okay. Okay. Oh, sorry, I forgot to mention one thing. Thank you, Ann. One of the other groups that Ann runs for us here is called GAP, Giving Alzheimer's Purpose. And these are the support groups that I was referring to for people with the disease who can come together, talk about struggles, day-to-day challenges, but also strategies, ways they make things work. I remember from one of our GAP groups, one example I'll give you is one couple said, you know, I was really afraid to go out. They loved the casino, and you know how confusing and busy the casino could be. And the wife was very nervous to go, and I don't know if this was your group or not, very nervous to go into the casino because she didn't want to get lost. So her husband said, well, we're matching shirts. I'm with her and he's with me, or however it goes with the arrow. So she knew if she got lost or couldn't find him, she could look down at the shirt and find the arrow, and he'd be on that side and where to look for him. So things like that. People compare notes, strategies, and really get a lot of good information and help and support and some laughs too together. So thank you.
Thank you, Jennifer. And thank you for letting us know, all of us know in this room, that they're not alone on this journey that can be very lonely. Next we have Heather Dober. Heather is a clinical social worker with licenses both in Massachusetts and Connecticut. She is currently a memory specialist and a behavioral health case manager with Fallon Health, and also a part-time counselor practicing in Connecticut, where she specializes in working with seniors and caregivers. She is also a volunteer support group facilitator for the Alzheimer's Association and is a certified trainer for the National Council of Dementia Care Workers. Heather?
Hello, good evening. How are ya? Good. So my name is Heather Daubert. Thank you so much for that wonderful introduction. I, like Ann said, I have a part-time private practice, and so what I do is I work a lot with people who are living with the early diagnosis of dementia, as well as their care partners. So some of the things that I see people facing when they get this diagnosis, obviously the elephant in the room is just the enormous grief that happens with any type of diagnosis that is not expected. Grief is a funny, very individual thing, and it never looks the same way in two different people. When I've watched different clients go through their grief process, I'm never surprised to see how it comes out very differently in each person. Some people become very tearful, very sad, very melancholy. Other people become very angry. Other people become disabled with fear because they just don't know what to do next. There's a lot of relationship changes that happen when this diagnosis is given. Whether you're the adult child of the person living with the disease, whether you are the sibling, whether you are the partner or spouse of the person, your whole life changes. And it changes slowly, unpredictably, and just when you get used to a new normal, everything changes again. So one of the most difficult things with dementia, with this disease, is that the trajectory of the disease, again, it's so different with every person. I think the Alzheimer's Association, I think you guys maybe took it from somebody, or maybe you thought of it. Once you've seen one person with dementia, you've seen one person with dementia. It's not like you can put them in a category like perhaps diabetes or hypothyroidism or some other medical conditions that tend to affect people in a very similar way. Dementia, the brain, is the most complex computer. I don't care about any artificial intelligence out there. Our brains are the most amazing computers that will ever exist, in my opinion. So there's a lot of different things going on up there. When someone is coping with the diagnosis, there's a lot of what we call anticipatory grief. It's grieving changes that haven't even happened yet. It's grieving changes that we're not even going to see coming. It's grieving a sense of change, of not being able to live life exactly as we had planned, as we had anticipated. And so holidays change. You know, relationships, phone calls change as you watch the person talk with people over the phone. The way the person interacts with people in the grocery store, the way they interact with people at the doctor's office, everything changes. And so a lot of what I do with people that I work with is we talk about, okay, what is going on now? What is going on today? What are the current things that you're faced with? And how can we problem solve around those to make you feel like a more capable, confident care partner? And so sometimes I work with couples, sometimes I work with individuals living with the disease, sometimes I work with the care partner or the caregiver. But a lot of what we talk about is living in the moment, controlling what we can, because there's so much that we can't control, right? With any chronic medical illness, there's so much of it that's out of our control, but trying to hone in on what we do have control over. And as a caregiver, as a care partner, we have control over thinking about the future, having things in place like Jen talked about as far as advanced directives, just all of those things that you can do to make things easier for yourself. I always encourage family members to have those family meetings, those family powwows, whether it's by Zoom, whether it's by phone, whatever it is, because it's important to talk about these things before you're in a crisis. Unfortunately, what I typically see is there's, let's say, for example, mom has dementia, dad is the primary caregiver, and perhaps there's 3 to 4 to 5 adult children. And maybe they're all over the country, maybe they're all in Connecticut. There's usually one person that's the primary person, not to stereotype, but it's often a daughter-in-law, that sort of manages all of the medical appointments, the doctor's issues, all that logistical stuff. And what I encourage family members and people to get used to early on is asking for help and building a team. And it's very easy to allow one person that's really good at management to kind of run the show for that person living with the disease. But it's very important to tap into other resources, because do you know what happens to that one person that's really good at it? What happens?
Burnout.
They burn out. They really do burn out. And if they burn out and they end up with medical conditions of their own, who exactly is going to take care of that person? You know, we don't know, right? When we are in a state of constant stress and our body is being flooded with cortisol nonstop, what do you think that does to the organs in your body? What do you think that does to your mental health? Not great stuff, right? Cortisol has a great purpose. right? If I'm out in the parking lot and I see a little toddler walking and there's a car about to back up, I'm gonna spring into superwoman action and I am gonna save that child, right? Cortisol has a purpose. When it's constantly up here and I have a hard time getting back to that normalcy, away from that fight or flight mode, it's just toxic for my body. So one of the biggest things that I talk about with caregivers is having a care plan for yourself. We talk about the care plan for the person, right? The doctor says, okay, I want you to do this, I want you to do this, I want you to do this. But what are you doing for yourself as that care partner? And oftentimes we tend to put the needs of the person first because that's just the nature of being a caregiver, right? You have that person in your mind all the time. But like they tell you on the airplane, put your own mask on before you help someone else. You cannot take care of someone else if you're not filling your own cup first. So I really kind of get very pushy sometimes with my clients, and I'm like, what are you doing for yourself? What are you doing to take care of your stress level and manage your life? And trying to empower them to reach out to the people in their life. Well, my daughter's busy. Well, my son is busy. Yes, they're busy, but could they call once a week and have a phone call with mom for a half an hour so that you can go next door and have coffee with your friend Betty? Could they organize a grocery delivery from Stop and Shop for you once a month? If you give them a list, could they go online and just do all that for you? Could you send them a list of things that their dad needs and they could go on Amazon or go to Kohl's and get them and just have them shipped? There's lots of creative ways that family members and friends can help, and it really does take a village. Also taking advantage of what we call more informal resources like churches. I know my church, I live in Granby, we get requests and calls all the time for a senior or a family that's living in the community and they're maybe a bit more isolated. They don't have any family in the area and they're just looking for some visits. They're looking for a friendly face. They're looking for a visit maybe from one of the therapy dogs to come to the home. Reach out, for those things because like Jen said, the social isolation with COVID, oh my goodness. I can't tell you how my phone was ringing off the hook during COVID with caregivers and care partners that just did not know what to do because we are social beings, we are social animals. Even the most introverted person in the world needs other people to live a really quality, healthy, productive life. And again, like Jen said, utilizing the support groups. I run a support group for Fallon in Worcester. And I kid you not, it is my favorite day of the month. And it is the most amazing support group that I've ever had the privilege to lead. You know why? Because sometimes, because I have kids, I can't show up. Because it's in Worcester and I live in Granby. And you know what they do anyway? They meet. And they carry on and they support each other. They give each other ideas. They validate what the other is going through, and they leave that group with hope that maybe they can manage this one particular issue just a little bit better. And some of the challenges that I work with family members, how do I get mom to take a shower? How do I get my brother to understand what's going on because he doesn't see her every day like I do? How do I keep her safe at night when she's more confused? How do I anticipate what the next stage is, what the next step is? Even though we don't know exactly what it looks like, there's some general ideas about the typical progression of the disease, things that we want to keep in mind to be prepared. Because when you're an educated and prepared caregiver, you're going to be a better caregiver, and just in terms of the quality of your caregiving, and you're taking care of yourself as well. Because no one who likes to be caught off guard, totally unprepared and stressed out. Does anybody? I don't think I've ever met a person that likes that. I've met people like, cops and EMTs and people that they thrive in stressful situations, but they don't seek it out. They like having a quiet day. Stress is not a fun thing, right? So what can we do to bring it down? And so like Jen said, the support groups, one of the beautiful things that has come out of COVID is virtual support groups. You can literally, you have a day off and you want to just get all the support you need, you can go to a support group every hour on the hour, all day long. I led a couple of weekly support groups during COVID that the association put together. And we had people from Montana, California, Florida, all over the country, right? So if you have that capability, and you can also call in by telephone, you don't have to do Zoom or anything, you can just call in by phone. There are so many options for support. And people will sometimes, I'll give you all the reasons that people say they don't want a support group. Well, I don't know, I don't want to hear everybody else's problems, it's just gonna bring me down. You know, or, oh, well, I don't like to share my business with other people, it's none of their business. It's, you know, something I'll talk about with my family. Well, I don't know that I really want to hear about what's in my future because it's depressing and I don't want to hear about it. There's lots of reasons that people don't go to support groups, and I'm not here to tell you to go or don't go. I got plenty of other things to do. But understand that every support group is different, and one may be a beautiful fit and another may not be. And yes, the future is scary, and yes, this disease is scary. But again, when we are stressed out, the one thing that decreases stress level across the board with any situation is control. If we can bring that locus of control back to ourselves in some way, okay, figuring out what we have control over in the situation, it decreases our stress level. It doesn't take it away. There's no magic wand, there's no cure yet for this disease, but it gives us a feeling of control. It allows us to feel like we're doing something. So please consider joining a support group, calling the helpline. They can do all the work for you, go through what time of day do you want a group. They have groups in the morning, groups on the weekend, groups in the evening, groups in person, groups online, whatever you're looking for, they have it. So that's just my push as a social worker. You know, when you go through training and you facilitate groups, there are things that happen in groups that you will never ever get in individual therapy. There just is. The group dynamic and the support that you get from your peers when someone is walking the walk that you're walking, you can't compare it to anything else. That brings me to the need for respite, again, for self-care, for taking a break. That's another way to utilize friends and family, right? So again, having the daughter call for an hour, or the neighbor stops by and says, you just let me know if there's anything we can do. What do we automatically say when people say, oh, what can I do? Is there anything I can do? Oh, thank you so much. Yeah, you know, it's been really difficult, and you try to paint that somewhat rosy picture when you are dog-ass tired and all you want to do is just collapse in that bed because you are just so exhausted. So when someone offers to help, say, oh, actually, yeah, I have 2 appointments next week. Is there any way that you could come and sit with her and have coffee for about 2 hours? And 9 times out of 10, they're going to say, sure, I'd love to. And you know what? If they're not free and they don't want to, well, shame on them for offering. You know, because now they're signed up, and it may be the start of a beautiful friendship between them and the other person, them and your loved one, okay? And then I just want to end with, the importance of the individual support piece. And again, that's what I do, both with the care consultations with Fallon and part-time with the private practice. Everybody in this room needs therapy at some point in your life. And if you're going to stand here and tell me that you don't, I'm going to call you a liar, and I'm going to tell you that you're in denial. Because life is one big trauma, it is one big stress, and it is a beautiful thing too. And we all need support, we all need help. And again, to say that, oh, I've got this, I'm okay, I've got friends, I've got family. I'll bet you do have family. I'll bet you do have friends, and I'll bet they're wonderful. And I'll bet there's a handful of things that you're not comfortable saying to them out loud that run through your mind every day because you don't want to worry them, you don't want to trouble them, you don't want to make them upset. And that's the beauty of a counselor, is that I can absorb all that stuff and not get weighed down like a family member would. and I can help you objectively look at the situation and figure out what can we do to help you, to help your mental health, to help your family members' mental health. So there's the old stigma of therapy. You know, people will turn to me and say, I'm not crazy, I don't need therapy. You know, mental health is just as important and significant as physical health. And again, anyone that doesn't believe that, I really hope that you turn the corner at some point, because I can tell you that having worked with, I've worked in nursing facilities, I've worked with people who are actively dying, I have worked with so many different types of individuals, and I can tell you the stuff that we don't deal with in our life, guess when it comes back? Through dementia. So the things that happen in our life, the challenges that we have, the traumas that we go through, and I don't just mean, obviously when we talk about trauma, we talk about trauma, like people have significant, horrible things that happen to them in their life. And we also have people that go through what we would call normal things. They go through perhaps a divorce, or they have a bout of cancer that they deal with for 10 years, or they relocate to another part of the country. That's traumatic, where they don't know anybody. It's important to talk about these things. So, you know, when I'm doing therapy with a caregiver, it's not all about the caregiver, but it's about just their own mental health as well. So you don't have to be a caregiver to get therapy. You can just need somebody to talk to. So, okay, I think that was everything I was going to talk about. So I'm going to turn it over to Tully. Oh, yes.
Thank you, Heather, for sharing such valuable information. And I'm just going to echo some of the things that Heather said of the importance of a caregiver support group. The caregiver support group that I run, I agree with Heather, it's one of my favorite days. At the end of every caregiver support group, I'm always just so impressed. It just happens to be one with all women, with the women on this caregiver support group and how they are there for one another and support one another. So I echo, it really is beautiful. We laugh, we cry, we laugh, we cry, we share resources. It's really an impressive group of women every time. Lastly, but certainly not least, we have Tully Meyer. She's been with McLean for 6 years as a community liaison for home care and hospice. Before working for home care and hospice, her experience was in skilled nursing homes and as a conservator. And Tully also is a wealth of information for community resources, and thank you for being here tonight, Tully.
Thanks, my leg's asleep, great. It's a great way to start a talk, is to fall on the floor. How do I follow these two? I got nothing. Oh, I do, I have something. I need help. Immediately. So I'm Tully, and I am going to be very brief because what I have to share is pretty concise. When I was asked to sit on this panel, my boss said to me, "What are you going to talk about?" And I'm like, well, that's kind of a good question. Well, what I'm going to talk about is what your insurance does cover and doesn't cover if you've had a diagnosis of Alzheimer's, and how we can, as a home care and hospice agency, help you, and how we can't help you with that diagnosis. So everyone in this room has insurance of some sort, Medicare or some derivative of Medicare. Has really two purposes. And one is that it will cover your care if you need to rehab, right? If you have an illness and you need to get better from it. And it will cover your care at the end of your life. But in between, it doesn't do a heck of a lot. And guess where Alzheimer's falls? Right in between, in that crack. And I've had many a discussion with physicians, and of course we believe it too with the rise of this diagnosis that there should be some coverage for it, but as of yet, there is not. You can get home care with your insurance coverage if you have Alzheimer's and you break your foot, if you have Alzheimer's and you wind up in the hospital with pneumonia, you have some other illness that occurs. You can access your insurance covered benefits. And at the very end of your life with an Alzheimer's diagnosis, you can take that rehab insurance and flip-flop it to your hospice benefit and utilize it then. But an Alzheimer's diagnosis in and of itself is typically not covered by hospice until you start to have other things that happen along with it. Let's see, what else do I want to talk about? Of course, I'm a big proponent for using insurance for anything you possibly can. And the reason insurance companies don't cover resources for Alzheimer's disease is because it's not something that they consider you are able to recover from. So everything else is recoverable. I have a little sheet over there with a side-by-side comparison, because again, I do go out into the community, I talk to physicians all the time, they have people come in, families, like, what am I supposed to do? And they get home care confused with home care, because they're basically called the same thing, which is incredibly confusing, but they get skilled home care confused with private duty home care. So I have this little comparison sheet. So what is covered under your home care benefit versus what you need to, if you need these other things, this would be a private duty type situation. Most of what people need in the height of their Alzheimer's diagnosis is private duty. So they may need help with their activities of daily living, medication reminders, things like that, which are typically through a private duty agency. Private duty, I know we talked about this, we touched on this before, is covered by money, long-term care insurance, VA benefits. So it's pretty cut and dry. Now, in speaking with Jennifer, I do know of other programs out there looming around that may be helpful, but I don't know enough to speak on them, just enough to be dangerous. And please, in that same vein, if you have questions about anything, please feel free to give me a call. I know, like I said, enough about a lot of things to be dangerous, and if I don't know the answer, I know someone who knows the answer. And that can be hugely helpful, so don't waste your time calling around for a lot of information that you may be able to get from me in one phone call. So I'm going to turn the microphone back over to Jennifer, because she's got some information to share with you regarding some programs the state has for help with private duty caregiving. Right?
Okay, good. So very briefly, what Tully is referring to, when we're looking for those private duty home care companion services, maybe someone to do activities or personal care, like you're talking about activities of daily living, maybe some grooming or a shower reminder or assistance with dressing, things like that. But also maybe to go out for a walk or read the newspaper, have coffee together if there's not family and friends around. All of that is private care and covered under the things Tully mentioned. But there are a couple of programs. The services are not cheap, right? So this is not an easy disease to pay for or care for. We're very fortunate at the Alzheimer's Association. We have a family who funds our respite care grant for us. It is a very small grant per person. It is $500 each year to a person to cover private duty care coming in, companion services, or adult day center services if someone attends an adult day center program. So it can be used towards those type of respite services. Now, me saying that, we all know $500 is not going to get you more, right? You can all roll your eyes, it's okay, but it's something, right? It's a drop in the bucket, but it's something. There's also bigger programs, something called the Connecticut State Respite Care Grant, Connecticut Statewide Respite Care Grant, as well as the National Family Caregiver Program. Those are both programs. They're not Medicaid programs or Title 19. They're grant programs through the Area Agency on Aging, and I would be happy to give you this information so you have it at your fingertips when someone asks. Those are programs that are grants that kind of bridge the gap between having not enough money and too much money to be eligible for things like Connecticut Home Care Program for Elders, which essentially is a waiver program to Title 19 for someone in nursing home care, but to receive home care at home at different levels. So I guess what I would say is that there are grants, there are programs, there are some income and asset guidelines that have to be met, but there are grants that you don't have to apply for Title 19 for that can help bridge the gap. I will tell you the statewide respite care grant is upwards of $7,500 in a year, so that gets you a little more assistance in care. And so just to know that those things are available, and the Area Agency on Aging is truly a wonderful agency to be connected with and ask those questions about any services and funding. So, and Heather has one more.
And I just have one more thing to piggyback on Tully's words. Home health care, physical therapy, and occupational therapy in home health care, that medical benefit is highly underutilized at times. It's important for you to understand that someone does not have to have a hospitalization to qualify for the medical home care that's covered. They can have a change in status, a change in condition. And that doesn't necessarily have to be completely pinpointed, like mom has pneumonia or mom had a fall. There may be a progression of the disease that has made that person have a new baseline, a new normal. And all of a sudden, mom used to be able to walk and put herself in bed, but now she's not able to anymore. So there's a fine line when someone has dementia in terms of making progress, because as Tully will say, in order to have that skilled benefit, there has to be that documented progress. The person has to somehow be making some improvement. And it's kind of counterintuitive because dementia goes the opposite direction, right? It's a disease that progresses downward, and here you have Medicare saying, well, you've got to go upward for me to cover you. However, it's quite possible sometimes the person may qualify for just a few physical therapy or occupational therapy visits where that therapist, and they're brilliant people. Occupational therapists especially, nothing against. So physical therapy is typically below the waist, occupational therapy is above the waist. So the occupational therapists are the ones that are helping manage the home environment. They're looking at how the bathroom is set up. They're looking at the lighting. They're looking at anything that can possibly make that person more independent, because like Jen said, use it or lose it. So if the person starts to require so much help that they can't do things for themselves anymore, they're gonna continue to decline. And we know the nature of the disease is that the person will ultimately decline, but we do sometimes have control over the rate at which that happens. And occupational therapists, they are brilliant people, and they see things just by observation and just by the way that you move in your environment that your loved ones are never going to pick up on. So be an advocate for your loved one, ask for that evaluation. The worst thing that's going to happen is they're not going to qualify, and at least you know that you've tried, but have the conversation with your doctor. So I'm not promising that it's going to be covered. I'm not promising anything, because again, dementia is a downward spiral, but the rate at which the person is declining can be affected by the support and the environmental things that are put into place. Simply reorganizing a bathroom or a bedroom or an entryway can make a huge difference for someone living with the disease. And therapists can pick up on these things. So just a little FYI.
Oh, the end. I don't really know why I have the microphone back, but I agree with Heather. I learned a ton tonight.
Okay. Thank you all for sharing such valuable information. It's really information that I wish I had 14 years ago when my parents were going through this journey of dementia, so thank you very much. We'd like to open it to questions now. Questions from anybody?
Yes, I just wanted to follow up on what Heather said. So,
Loud.
sorry. In order to have an occupational,
just to follow up on what you were talking about. So in order for an occupational therapist to come out, you would work through your primary care physician to arrange that? Okay.
Correct. And so you need to, so typically occupational therapy, I could be wrong, correct me if I'm wrong, you need either a physical therapist or a nurse to open the case. So occupational therapy will typically piggyback on physical therapy. But regardless, yes, it goes through the doctor's office, and usually the nurse just sends a referral over to whichever agency they work with, or if you know of an agency, like McLean, that you would prefer, you would just tell the nurse, please make a referral to McLean for home health care. And you tell them exactly what you're looking for, because what you don't want is for them to see that diagnosis of Alzheimer's and be like, well, why? What's going on? So when you call, you want to be prepared, and you want to say to the nurse, I have noticed these 3 changes in my mom. She used to be able to do this, now she's doing this. And in the bathroom, she used to be able to do this, and now she's doing this. And again, the question becomes, can the person, learn new information? And sometimes it's a matter of the fact that they're not going to cover a ton of visits, but they can put a plan together for the family to say, listen, this is what you need to do to strengthen mom's upper extremities so she has the strength to push herself up from the toilet, from the commode, from the bed. These are the daily exercises that you can do with her to keep her as high functioning as possible. So they're not going to come in and wave a magic wand and all of a sudden make everything easier. They're going to tell you as a family what you can do to try to keep mom going as good as she can for as long as she can, if that makes sense. Okay.
Yeah, I mean, just having anybody, any professional clinician come into the home and help you look at things through a different lens is totally worth it. And of course, if you get the home care benefit and you have home care come in, we also have a social worker on staff. So they don't, again, of course, I'm part of that generation too, was like, I don't need a social worker, I'm not crazy. But what they are is they're resource workers. They can help you with that team, putting that team together. There's so many benefits to having an outside person come in and kind of see things from a different angle.
Jennifer, I was just wondering if you could speak to that as a care consultant for the Alzheimer's Association. What does the Alzheimer's Association do in that capacity?
Sure. So through our helpline, we have information and referral services and care consultation services. If you're calling, similar to what Tully is speaking to, if you're looking for information on home health care services or companion services or adult day or support, looking for a support group, looking for a physician, a specialist, an elder law attorney, just about anything, we can provide information and referral resources. We don't refer one place over another. We try to give you choice and empower you to choose who you would like to work with for different services. On the flip side of that, we also do care consultations. So my role in particular, I'm a dementia care consultant with our health system. So I work with a lot of referrals that come from different health systems like Yale. They're one of our partners. So if someone walks into the office in their neurology department and is diagnosed and the caregiver is with them, they're going to support and help the person living with the disease and give them referrals to things like occupational therapy, speech therapy, and set them on their way. And they will make the referral to me to reach out to the caregiver to help the caregiver with their care plan and what's next and what next steps to take. That care consultation for anyone, not by health system referral, is what goes through our helpline. And so right here in Connecticut, Amanda Lamb Moretti is our helpline manager. And so if you are a caregiver who is caring for somebody newly diagnosed or a person newly diagnosed, it doesn't matter who, Amanda is our care consultant for our helpline here in Connecticut. And you can call our national number as well if you want to do something at 2 o'clock in the morning, because that's the time you have. You can schedule a care consultation or talk with someone on the spot and have care consultation. What that includes is conversation, talking about exactly what Heather was saying. What's happening now? What's happening here and today? Is there an immediate or acute situation that you want to work through? Is the person you're caring for walking out that door right now thinking it's Sunday and going to church and it's Tuesday at 1 a.m. and you don't know how to stop them? How can we talk through this? It's not a crisis line, so if you do need 911, that we're going to encourage you to do that. But we can talk through immediate situations or behaviors, ways to de-escalate a situation. Or it can be a care consultation that you're thinking of, hey, I really would like to look into this respite care thing. What does it entail? What's available to me in my area? You know, how do I introduce that? What's the conversation I have with the person I'm caring for to get them to accept help or go to an adult day center or, you know, move with me into an assisted living or memory care unit? You know, so it's really a conversation and care plan for the caregiver when we do our dementia care consultations. Does that answer your question?
Yes.
Okay, good.
Actually, another question for you, Jennifer, is in our caregiver support group, some of the people who've been involved have had a lot of satisfaction using, I think it's Alzheimer's Connect? Yes, can you, either of you speak to that?
It's the online,
So
chat
I'm,
board or whatever it's called.
okay, so, oh my goodness, I am not technical, and so I'm gonna give it my best guess with Heather's support, but on our website, I do know we have, it's like a blog or a chat room, right? And so one half is for the person living with the disease, and the other half is for caregiver. I'm visualizing this, so please forgive me. But you can click on if you are the person with the disease, or you can click on if you're a caregiver. And basically what it is a conversation online, like a chat room online for caregivers to, just like in a support group, share questions, information, ask what maybe somebody else is doing in this situation, and exchange back and forth in conversation, but online, typing it in a chat room that way. Thank you.
Yeah.
Yeah, I've had some,
What's nice about it is that it's not a timing thing like a support group. Like if you're feeling like you can't commit or go to one more thing because you've got so many appointments and you're up at 10 o'clock and can't sleep, not that you should really be on the computer if you can't sleep, because the blue light isn't good for sleep, but you can go on at any time and just see what other people are going through. And it can be helpful just to know that you're not alone, that someone else is maybe going through what you went through today.
And one more thing I'm just gonna mention, I know it's often hard sometimes for caregivers to talk on the phone to me. If I'm on the phone or on Zoom with someone doing a care consultation, you know, there have been times where I'm doing care consultation and in the door walks the person half dressed and not quite sure what, and I'm like, okay, we'll pick this up another time. It's hard to talk sometimes, so it's easier to type. Sometimes people will email me questions or do that chat, that ALZ Connect to ask questions and things like that. And I was doing this because I told Heather I did bring my blue light glasses tonight, which don't help me a bit to read what I wrote on here to share with you.
so yeah, we've had people in our caregiver support group have really found a lot of satisfaction with the Alzheimer's Connect, so yes, thank you. Any more questions in the group, sir?
Thank you, and thank you for reaching out to us as your potential consumers. I'm a former director of clinical psychology and former associate professor of psychiatry. And so I've supervised a lot of attending physicians, a lot of caregivers. I'm also a family therapist, so I always tried to bring in people. But a couple of concerns I have. But let me just give you some data. Lifespan for men in the last 30 years has increased by 10 years. In the last 30 years, I didn't look up the issues for women, but for men, our lifespan has been increased by 10 years, which means we have more time to get rusty and broken and so on at all levels. I am concerned about the way aging is viewed in our society. This is a youth-emphasized society. We want to get cosmetic surgery to look younger. We want to participate in tennis when we're 80, whatever. And it shows up in the caregivers. I once gathered my 90-plus students, doctoral students, and I said, how many of you want to work with the fastest growing population in need in the country? About 3/4 of them raised their hands. I said, now how many of you want to work with the elderly, which is the fastest growing group? Only 2 people raised their hands. And 3 months later, when I ran into them, I said, are you still interested in working with the elderly? And they said, no, we want to work with adolescents. So the perception by the culture is that while we may be loved, Mom may be loved for the apple pie she used to make, and Dad because he was a good money manager. The cultural trend is to emphasize youthfulness. And some countries, like Switzerland, for instance, do not do that. They make all the sort of heirs to the family responsible for residence, for food, for medical care, etc. So my one question is, while I commend you reaching out to us, are you also reaching out to physicians who should not take for granted, physicians and any health workers? I've run into repeated situations where my fellow professionals, me included, should not be practicing anymore because their memory isn't as good as it used to be, because their capacity for endless suffering to hear it. So we have burnout amongst the professionals as well. And it's been, patients have come to me with innumerable complaints about their old doctor so-and-so, okay, falling asleep, not being able to remember, making the wrong diagnosis, and so on. So I'm concerned about burnout in the caregivers, and I'd like to know whether the panel finds opportunity or is looking for opportunity to address health professionals and their own situations with regard to aging. And I've heard some terrible stories over the years about how mistakes were made. So anything you want to, like recommending they get a second opinion, for instance, not just rely on old doctor, whoever, to be the definitive word, when he can no longer or she can no longer do it. Don't want to admit that to themselves. Sorry to be a little wingman.
So I'm gonna make a couple of comments, and I'm guessing you have a few things to share as well. So number one, I wanted to share with you, when I was in college years ago, I'll never forget his name, Dr. Stowe was one of my psychology professors, and he said to me, if you want a job and you want to enjoy your job, go into the profession of gerontology or geriatrics, work with elderly, work with older, and I already had it in my mind because of my relationship with my grandparents and my family members. That's just always what I wanted to do. I didn't necessarily know Alzheimer's, but I knew I was going to go into that. But I will never forget him saying that, because he did the same as you in the class, and not many people wanted to go into the field or work with that population. I feel blessed that I wanted to, because this is life work. I don't feel like it's a job. I'm going to say something to you, and I was saying to Heather, I cannot remember for the life of me. There's a practitioner, I'm sure you've had him here speaking, Dr. Harry Morgan. Yes, so he is the doctor I first started working with 25 years ago, 30 years ago. When I first started my first job, he was the practicing geriatric psychiatrist that I ran the unit and worked with. He taught me everything about Lewy body, dementia, Alzheimer's, so I hold him in such high regard. When I had a call from a family, 2 daughters, concerned about their father who was a practicing surgeon, couldn't find his way to work or remember how to work the car, but was a still practicing physician, this was years ago, and wanted to know what to do, but were afraid to address it with him. So I hear, when you're saying that piece, so I think there were a couple of facets to what you were asking, so I'm gonna try to kind of go each one briefly. Dr. Morgan, and I'm going to find out for you and take your name and share it with you. There was an organization, I called him right away and said, what do I give this family for this physician in support? Because they need a diagnosis, they need an evaluation, they need some type of support. And Dr. Morgan gave me the organization for physicians, and had shared with me that year that they were putting the cutoff age of 70 to have, whether it was a neurological evaluation or something for practicing physicians. I'm gonna find out the name of that organization for you. It's such a simple name, and for the life of me, I can't recall it. I will find it for you and get it to you. But there is an organization supporting physicians in that regard that have memory concerns that are, and they're, I guess, to have people on their radar, if that makes sense. In terms of physician outreach as an organization at the Alzheimer's Association, part of my work with health systems, obviously, is to help the patients that are being diagnosed that they refer to us, but general practitioner, right, primary care physicians, those are the ones everybody is seeing, and because they're not with a specialist yet, we do outreach and try to get all of the information that we can in regards to what is covered, and they can bill Medicare for an initial assessment or conversation in that annual visit regarding memory concerns and dementia. And we try to educate those physicians as well, whether it's through grand rounds, through their hospital system, which then trickles to some physicians' offices. But we have an outreach for physicians to try to educate, give them the tools, and at least our helpline for people, okay? And then I think another piece of it was you were talking to supporting physicians who may be also caring in a caregiving role. Was that a part of your question or no?
They themselves are aging and
Right.
need to admit they're less than they used to be.
Okay.
And how do we get them to be sensitive to that? Hartford Hospital, for instance, makes every physician over 65 take a periodic cognitive test to see whether they've still got it.
That's
in
what I'm
order to
talking
do any
about.
admitting or
Right.
attended.
That was what I was talking about. I think that Dr. Morgan had referred to, and I'm gonna find the name of that. If you call them and have a conversation with them, they can share with you what they're doing, why they're doing it, how they're doing it, screening, and how they're keeping people kind of on their radar.
And so I would imagine that when they make that recommendation, larger organizations like Trinity and Hartford Healthcare and Yale, they're more apt to follow those recommendations. The community doctor out in the sticks of Connecticut, who's not affiliated with any of that, is not likely to really care what the recommendation is. And I think one of the issues that I've found with physicians is, and I get this, because as we all get older, it's harder to see an issue in a peer relationship versus when there's a generation removed, right? It's very, for me to say, okay, yes, this is, so in 25 years, maybe I'll have this issue, but when I'm looking face to face with someone that I've been treating as a physician for 40 years, and you've seen them go through every milestone, you've just seen their kids grown up, for a lot of doctors, it makes them very uncomfortable. And it's a lot easier to explain something as being normal than to think that there might be an issue. Because if they're describing the same issues that that physician is having, that physician is gonna wanna just kind of say, oh, well, it's normal, we get overwhelmed, it could be this, it could be that. The Alzheimer's Association has tools, and I think that one of the most important things to remember is that we can't change the world, right? One of the challenges is that Medicare doesn't pay as much as the other insurance companies. I'll tell you that right now because I build them all. And there's a couple that don't pay well at all, but you can negotiate your rates. But in general, as a physician, you're not getting as much money from Medicare as you are from Aetna or Cigna or Connecticut. And so when you have a managed care program and you're under 65, as a doctor treating those patients, you're gonna get paid more. So it does come down to that bottom dollar, honestly. So when you look at people that are becoming doctors, and you can become an orthopedic surgeon and make beaucoup money, or you can become a geriatrician where you're billing Medicare, or managed Medicare. We have managed Medicare plans now as well. But in general, I think that that dollar sign is what is appealing to younger doctors. So I think that's kind of one of the core issues, that just the rates are not great. But I do think it's important for family members and people living with the disease to be empowered to know to ask the right questions, because the doctors and nurses in the offices don't even necessarily know the right questions to ask. What makes me want to jump into one of these offices and just strangle people is when they say, well, she knew what the date was, she was able to draw a clock, and she knew where she was. Okay, so what? That tells me nothing. I want to know what she's like on a daily basis when she's not here in a doctor's office performing in front of the doctor. Because who hasn't performed for a doctor before? You're sitting there and you're, so what, yeah, I'm exercising 3 or 4 times a day, and I'm putting less sugar in my coffee, doc, because I
do not drink.
Oh, I don't drink alcohol, only 1 to 2 drinks a day, which you're gonna double that, is when you're taking your notes as the clinician, right? The way the person presents in the doctor's office does not come close to how they present on a daily basis. So one of the tools that the association has that I sometimes mail and print for people is like it's how to communicate with your doctor, you know which one I mean? And it goes through these different facets of the disease where you can take notes and be prepared in that office. And when the doctor says she's fine, you say, no, she's not. And this is why. And you have to be that advocate and push back. And if the doctor has a problem with that, you need to find a new doctor. That's just the way it is. And I don't mean to be flip, because I know that it's not easy to find doctors. Sometimes you have to wait a long time to get in with a doctor, but you need to be an educated consumer. Just like if you're buying a car or you're buying an insurance plan or anything else that you're investing, you want to make sure that your doctor is doing right by you and your family. So the onus does fall on you to know what questions to ask and to know what information to give that doctor. Because just simply going there and expecting them to ask all the right questions and do the right thing, you're going to be waiting a long time for that to happen. Some doctors have it together and they do a fantastic job. Fantastic. I've had the privilege, I think we've all had the privilege of working with some amazing doctors. And then there's others that are okay, they're there, but aging isn't their thing. They just don't have the training in it. They don't know. They don't know what they don't know. So you have to figure out what you know, what you can bring to them. Because sometimes you're educating them. It's so true, you know? So, anyway.
Any more questions? I have one more question, and maybe either of you could speak to it, about important paperwork to have at the ready and where that should be kept.
Okay, we'll do this together. I'm gonna tell you, no matter where you keep it, tell your spouse or adult children or whoever needs to find it. One of my coworkers for years, she's now with Hartford Healthcare, had her father and mother filled out all the paperwork, had everything ready for emergency, never told her where it was, and when the emergency came, she was like, I don't know. No, they have it. So making sure whether it's in a safe box or a safe or wherever, let someone know where you're putting that. For me, what I would say are important papers. Number one, if you don't have it already, that file of life, do you know about that? It's on your refrigerator. It's got your medications, your health conditions, anything a first responder, emergency person should know in emergency. I don't know who she was waving to, but I waved, sorry.
I waved too. I don't know her, but we said hello.
Yeah, that's right. So anything that a first responder, emergency person should know, that will be on your fridge, and they know to look for that on the refrigerator. Other than that, what I would say is if you are a do not resuscitate or you're a DNR, you don't want to be resuscitated, if you have that bracelet or that paperwork, make sure the bracelet is on, or the paperwork and the bracelet are somewhere that someone who's with you can access before the emergency responders get there. If you have a living will, that's great, but the emergency responders, I don't feel that's paperwork enough for them. That's good in hospital.
No, I have several family members that are first responders, and you can talk to them till you're blue in the face and tell them that they're a DNR. If you don't have that paperwork, they're gonna work them like they're a full code.
Right. So, power of attorney, healthcare representative, so I have not done 5 wishes, but there is a document, 5 wishes, that you can have filled out and put your wishes and your voice on there, so people know what your online 5 wishes.
And it's nice because it talks about some of the things that the living will doesn't. The living will is a document that talks about 3 things: CPR, a feeding tube, and intravenous fluids. Those are all important things to talk about, but there's about 1 million other things that could happen, and 1 million other medical conditions that you could develop. And it's important that your family understands, okay, if I am in the moderate to advanced stages of dementia and I all of a sudden need dialysis because of kidney failure, please do not take me to dialysis. Please do not give me a colonoscopy at 75 if I don't know where I am or where I'm going. This is what I want for comfort. I want somebody to do X, Y, Z for me. These are the 3 things that are important for me in terms of pain management. This is the type of touch that I like. This is the type of touch that makes me crazy. Don't let anybody, like my daughter hates having her head touched, her hair, she's very sensory. If someone hates having a part of their body touched, these are things that you want to make sure, because this document can be replicated and given to the hospital, to different providers. Having these conversations. And the last, Oh yeah, the Conversation Project as well, online, that has just, again, it's a whole conversation about end of life and, you know, planning for, we talk about palliative care versus hospice, and kind of, we don't have enough time to go into all that, but basically, you know, if you have a chronic condition that requires management, you want to communicate what your wishes are surrounding the treatment for that condition. And you want to do it now when you are clear, when you understand. I mean, any of us, God forbid, knock on wood, could have a stroke tomorrow, could fall down and hit our head and not be able to tell our loved ones what we want and don't want. And I'll tell you right now, I am guilty of this. I don't even have a will, Jen.
Not yet.
I have
an
two-
attorney to do the will.
I have
don't
two
know.
children and I do not have a will because, you know, I don't know. We just know that, I don't know. It's an understanding in the family as to who would get the kids. I don't know. But it's important to have these things and just have the conversations. And the last thing I want to mention is amazing little book that you can find online on Amazon called, the author is an occupational therapist named Lanny Butler, Bulter. And he was a speaker that I heard a long time ago, and he has this document in there called My Way, and it's a wonderful document that helps the person communicate how they want things done for themselves when they can't communicate, such as, what is my way? Everybody close your eyes for 1 minute. Imagine, what body part do you start with when you shower? For me, it's my left arm. Now, you don't have to tell me what it is. We don't need to get that personal. But if I'm an occupational therapist or a physical therapist trying to help you and you have dementia, it's gonna go a lot smoother if I do things your way, not my way. So if I know the order that you get dressed in the morning, do you put your shirt on first? Do you put your, I met a guy who was like, I put my socks on. I'm like, who puts their socks on first? Like, that was the most bizarre thing to me. I would never think of that. But, you know, and how do I drink my orange juice? I love the pulpy orange juice, maybe. Just getting things the way you need them. Because it makes a world of a difference for someone living with the disease when you give them what they want, when you give them what they need, when you anticipate what their preferences are. I mean, aren't we all happier if we're given ice cream that we like, or if we get to go on a vacation to a place that we like? If we're a city person and we go on vacation in the country, are we gonna be happy? Not so much. So it's important that your caregivers know what makes you tick and that that's communicated to other people.
So I did bring, I don't have many of them, but I did bring legal plans. So if you are looking for like what those documents are, it doesn't have everything in it. Like this is definitely a whole other conversation, and I think you should invite a wonderful elder law attorney here. Oh, good. So I'm not have a good name, but to go through that, I mean, just like this conversation, this is a care consultation with a very big group, but you don't know until you talk with everybody. Like I forget about the Conversation Project, and I know about 5 Wishes. I just learned about this great new book. Like we have to talk, we have to know. This one has kind of like the black and white, you know, power of attorney, healthcare proxy, will, living trust, whatever. It has some of the documents you need, not all of the good ones I would consider.
The softer ones.
Right, but the good ones, because that's your personal preference, and that's what people need to know caring for you.
I just have one little, the Conversation Project, if you guys want a copy of it, reach out to me. You can do it in pencil. It's a gift to your family is kind of how I think about it, because you won't leave them guessing, like, what would she want, and the guilt after making decisions, or what would he want. More importantly, it's kind of my own little personal bugaboo throughout my career, is that a DNR is different than a living will. I just want to make that clear, right? They're 2 different documents. So a DNR, you don't want to be resuscitated, or you do want to be resuscitated, but say it goes poorly. That's when you institute your living will, because you don't want to remain that way, but you want them to try. So they're 2 separate, and I know they get spoken about interchangeably, and they're not. So I just wanted to clarify that. If there is any confusion, it's get on my high horse, ride all the way to, I don't know where, back to West Hartford. So that's it for me.
This is why it's good to have a panel. Together, we can piece it all together.
Together, we're
Yes.
one brain.
Any other questions?
I'm It's not really a question, and I've got a teacher voice, so I think you can hear me. Retired. Elder care lawyer told us, yes, you have all these important papers now. Yes, you can carry maybe this paper with you when you take your spouse to the doctor. But when you have the rest of them in your safety deposit box, put one of your children on the box also. Because eventually, yes, if you die, they can get on it, but there's a lot of red tape to go through it. So we put our daughter who lives closest to us is also on that safety deposit box now. So she knows what the papers are and she can get them.
Yes.
And I would just echo that, the same thing with bank accounts. Have someone else on your bank account, especially as you get older, because if all of a sudden something happens to you as the care partner and your husband does not have the cognitive ability to do checks, somebody's gotta pay bills, somebody's gotta take money out to pay the private caregiver, somebody's gotta pay the mortgage. So it's a lot easier with the bank if you just have somebody. You can go in with the power of attorney, but it can get a little sticky. If you have somebody, if you have your daughter or son or nephew or someone on, if you trust someone enough to be on that account, it's so much easier for them to come in and do whatever's necessary financially.
Faster too.
Yeah, much faster.
Other questions?
Faster.
Well, I just want to thank you all tonight for sharing such a wealth of information. It was a great panel, a lot of great information to share with our group tonight. I just want to reiterate that we all need to continue to elevate this conversation of dementia and eliminate the shame that still goes along with this disease. So thank you for tonight helping us elevate this conversation and letting everybody in this room know that they're not alone. Just a couple of quick notes. This week we've been highlighting the assisted living up at our health center. Tomorrow, for anyone who's interested, we're showcasing our adaptive bikes in front of the health center from 2 to 4. We also have an open house at the assisted living health center from 10 to 12 this Saturday. And I think on your table you have information on our next M&M event, which is McLean Home Care and Hospice. We'll have Fox Rehabilitation, home helpers, and it's to help navigate home care. Is that correct? I think, Tully, you're back on that panel.
Yeah, you guys.
So thank you all for coming tonight. I appreciate your time.
Sorry in advance.